Hello, everybody. I'm Professor Atul Pathak, cardiologist, head of the Department of Cardiovascular Medicine here at Monaco, but also president of the French Society of Hypertension and one of the co-author of the consensus paper I would like to share with you. So basically, this paper is really important in the field because you have to remind where we were standing a couple of years ago. We had the release of the European guidelines stating that renal denervation was not at all appropriate for routine treatment in hypertensive patients, and the only way to offer renal denervation was to include patients in trials or registry. But there have been dramatic changes in the last 4 years, and this slide is showing you that finally we have been able to confirm that renal denervation per se or on the top of drugs is able to reduce significantly blood pressure, whether the device is based on radio frequency or using ultrasound. And I think this is really important because these trials have really reshaped the field and led to a couple of new guidelines coming from all parts of the world. And the European Society finally decided to update their position paper, their guidelines with this new position paper published a year ago, stating that finally renal denervation was probably an evidence-based option to treat hypertension, that it was able to reduce blood pressure, it was a safe procedure, and it could be considered as an alternative or an additive option for hypertensive patients. And it's in this setting that this consensus statement came up, taking into account the knowledge from the past, the recent trials, and how also renal denervation could be offered in clinical practice to our patient. And I'm going to share with you a couple of key takeaway points. First, I think that, as I stated, we have this high level of evidence now with at least 5 to even 6 trials showing in a randomized fashion, controlled trials versus sham, that renal denervation is able to reduce blood pressure, whether office blood pressure or 24 hours blood pressure recording for both radio frequency and ultrasound renal denervation in a broad range of patients, starting from mild to moderate hypertensive patients to more severe or uncontrolled or even resistant hypertensive patients. Second point and third point is that basically this therapy is safe. There were no significant procedure-related safety concerns beyond the risk associated with the access. And this is a really important message. Short-term, mid-term, long-term follow-up of patients have shown that there are really no risk offering this therapy to our patient. If you follow up, for example, kidney function, if you do regular imaging, there were no signal about renal artery stenosis or worsening kidney function. So really, I think it's a very important message. The benefit-risk ratio is in favor of the therapy. Beyond trials, we also got results from registries and from other type of trial showing that the therapy was not only able to lower blood pressure as a short-term effect after 2, 3, 6 months, but also the effect was lasting for at least 3 years regarding the latest data coming up from observational studies. A very important point is that we have also learned that renal denervation could also be a solution for patients who are non-adherent. We know that 50% of our hypertensive patients who are supposed to take 3 or more drugs are not taking them. And in this case, renal denervation could be an option. So in practice, who could be a patient candidate for renal denervation? Well, a patient, an adult patient with uncontrolled hypertension, where the blood pressures numbers are above 140/90 when you measure blood pressure in your office, or 135 for systolic daytime blood pressure, treated with 3 drugs with a GFR above 40 milliliter per minute. The other very important message is that RDN could also be a treatment for those of these patients who are unable to tolerate antihypertensive treatment, and this could be offered to them at any stage of their natural history. You need to share medical knowledge and information with them. You need to take into account their preferences, but there are a lot of these patients who do not tolerate antihypertensive drugs and who could also be candidate for renal denervation. Finally, if you move forward and you go a little bit a step ahead the aim of controlling blood pressure, you also need to take into account the global cardiovascular risk, but also target organ damage mediated by hypertension and sometimes also cardiovascular complications, especially in those mild to moderate hypertensive patients where you might hesitate. While taking into account the patient in a more holistic way could also be a good way to identify candidates for renal denervation. Finally, and I think it's politically correct, but also clinically relevant, the decision-making process should really incorporate the preference of the patient, but also we should be sure that the patient has been well informed and educated about the benefit and the risk of the therapy. And now the final point, the 10th one, the last point is that if you want to set up a renal denervation program, you need to build up a multidisciplinary team because we know these patients are difficult to treat. You need to exclude secondary causes. You need to be sure that the interventional cardiologist is doing a good job. You need to set up the follow-up. And so renal denervation is only one tool in the armamentarium we have regarding the management of these hypertensive patients who have to be taken into a larger framework, which is a multidisciplinary clinic. Finally, as a conclusion, I think that this consensus paper is really important because it's not only offering the therapy for our patient for the very near future, our hypertensive patient, but it's also opening the path for future indication. And you have here a different situation known to be associated with elevated sympathetic drive to the heart, where there are atrial fibrillation or sleep apnea, and there are currently trials investigating renal denervation beyond hypertension. As a clinician, I also think that this paper will have a large impact in our community. Patients will now start to ask for renal denervation. GPs and cardiologists will start to refer these patients to centers which are specialized in the field. And I really believe that having renal denervation available will help us to better control these uncontrolled so-called resistant hypertensive patients, but also help these patients who are unable to tolerate drugs or are called usually non-adherent. Thank you for your attention.